Evening, good afternoon, wherever you are in the world. We are into the fifth module of our certification course in uro-oncology. And from today onwards, until about a month, in 4 webinars, we'll be discussing T2 to T4 metastatic RCC. We have in the first 3 modules have discussed the small renal masses and its management. So the program for tonight is radical nephrectomy, various approaches, including open, lab, and robot-assisted. This half-an-hour talk will be by Dr. Zishan Aslam, who, as you all know, you're very well known to the community in Pakistan and to the certification course delegate, is a consultant urologist with a special interest in kidney cancer and is currently working in Aberdeen. This will be followed by another talk on the SABR or SBRT for primary kidney cancer by Professor Rakibul Hanan. We also have the pleasure of having him in the previous webinar. And in the end will be a talk on IVC thrombectomy by Professor Jose Karam. So let me introduce our 3 speakers for tonight, and we are very fortunate to have Professor Jose Karam in today's webinar. He's a world-known authority on kidney cancer, and his particular interest is advanced kidney cancer surgery, particularly in relation to IVC thrombus. He is a professor of and department head of surgery in University of Texas, MD Anderson Cancer Center, as you all know, one of the most famous place for cancer management in the world. We also have Professor Rakibul Hanan. We all have the honor of having him in the previous webinar. Professor Hanan is Chief of Genitourinary Radiation Oncology Service at UT Southwestern. Again, a very famous place for cancer. And we are very fortunate to have him tonight as well. And he's going to talk about SBRT in primary RCC. And we have Mr. Zishan Aslam, consultant urologist in Aberdeen, a well-known personality in Pakistan, and to the course delegates. Just as a reminder, our next webinar is going to be on ERAS for kidney cancer, role of cytoreductive nephrectomy in metastatic cancer, oligometastatic kidney cancer, and the role of SBRT, an indication and protocol of systemic therapy. So this is going to be an exciting 2 or 3 sessions on advanced kidney cancer, and I hope our delegates will benefit from this. So without any further ado, I will request Mr. Zishan Aslam to please share the screen, and I'm going to unshare Zishan, and you can.
Yeah, Prof, I just wanted to please mention, and if that is okay with you, I think there has been some timing issues with the change of clock, and Professor Karam was thinking his talk is at this hour rather than an hour later. So I hope it's okay if we can start with Professor Karam's.
Oh, yeah, wonderful. That would be no issues at all.
Thank you very much. Good morning, everyone, and sorry about the confusion on my part.
Not at all.
I made the plans I thought it was starting at 10 a.m. Houston time, so I apologize, and I appreciate your allowing me to start a bit earlier. And thank you very much for having me here today. Let me see. So this is what I'm going to be talking about today. Let me see if I can go. Can you see this well right now?
Yes, we can. Perfect.
Okay, perfect. And I'll keep an eye on time as well because the talk is actually a bit longer, but I know that the session is only 30 minutes, so I'll be cutting down some slides at the end. And again, I'm very grateful to be here with you today, and thank you for accommodating me. And it's a pleasure to be here at the certification course in uro-oncology with several of my colleagues, Dr. Aslam and Dr. Hanan as well, whom I've known very well. These are my disclosures. So today the talk is about IVC thrombus in patients with kidney cancer. And just to make sure we're all on the same page, this is the AJCC staging. So the true IVC thrombi are T3B and T3C, either below the diaphragm or above the diaphragm. And one thing that sometimes we forget about is the IVC wall invasion that automatically puts you at T3C stage. Now, there is another classification which we use more commonly in the surgical setting, and this is the Neves-Zinke classification from Mayo Clinic. Again, for this one, level 0 is in the renal vein and not in the IVC yet. Level 1 is less than 2 centimeters above the renal vein. Level 2 is more than 2 centimeters above the renal vein, but below the hepatic veins. And level 3 is at or above the hepatic veins, but below the diaphragm. And level 4 is extending above the diaphragm. These are the topics I'm going to cover. I'm going to skip some of them just for the sake of time. But this is our recent experience with this. One of our fellows put this together, looking at patients from 1993 to 2009. So we're currently updating these data since this is already more than 15 years old. We looked at 265 patients with an actual just IVC thrombus. We're not counting the renal vein thrombus here. As you could tell, most of them are T3B. There's about 20% are clinically node positive, and almost half have metastatic disease. Most of these patients, as expected, have clear cell and have high-grade histology. We used to use embolization more than 20 years ago, but we don't really do that anymore prior to surgery, and except for one clinical scenario, which I'll get to later. So when we looked at our data in this manuscript, these are the predictors of survival. Again, these are not surprising at all. If you have T3C, N1, M1, it's going to be a very poor prognosis. And then if you have more than one, obviously it's even worse. So when you look at the data here, the line in green on the left, this is patients who have 2 or 3 of these risk factors, and you can see their survival is quite poor, both recurrence-free survival and overall survival. However, if you have none of these risk factors, your survival is still actually pretty good. And we developed a nomogram to include all these T and M stages. As you could see, though, unfortunately, the C index is not great. It's only 0.65. This is multi-institutional data with colleagues from different centers, from 5 centers to be specific, looking at data also a bit old, a little over 10 years ago here, 427 patients. These are patients who had a venous tumor thrombus, but they were all metastatic patients, so they had M1 disease. The mortality rate at the time was still quite high, and I think the numbers now are better. But 3% died within the first 30 days of surgery with a follow-up of a little over a year. And the survival, as you could see, is about a year and a half. These are all metastatic, and this is, again, patients from more than 10 years ago. So we are currently looking at updating these data. As expected, if you have IVC tumor thrombus above the diaphragm, and that's the line in red, the outcomes are worse. And these are the predictors of poor outcomes. If you have systemic symptoms, if you have a high LDH, if you have a level 4 tumor thrombus, and if on final pathology you have sarcomatoid elements. Again, we've developed a way to try to figure out who likely might benefit from surgery, depending on the number of risk factors. And we know that patients who have an atrial thrombus in the metastatic setting, their survival is going to be very, very poor. So in general, we don't do upfront surgery in these patients if they have metastatic disease. So just going back to some basics here of preoperative preparation. Of course, we do a basic history and physical labs. Generally, we like to do an MRI in these patients. I generally favor a CT scan in my kidney cancer patients, but MRI, I usually do it for these patients with a tumor thrombus, and I'll go into details in a second. These are some of the elements on history and physical that you want to look at, including shortness of breath, increased abdominal girth, lower extremity edema. Labs are the usual laboratory studies from chemistries to hematology to coagulation factors. So the benefit of MRI in this setting is that it will tell you where the tumor thrombus is exactly. It could help differentiate between the tumor thrombus and inflamed thrombus. It could show you the venous collaterals. And one of the most important points in this lecture, if you're going to take one point only today, is make sure you have very recent imaging before surgery. I generally try to do imaging within 1 week of surgery. And I know this is difficult and it might not be realistic in some places or some settings, but this is the one thing I want you to remember from the half hours I'm going to be talking today. Just try to make sure the imaging is recent. Of course, we need to do a metastatic workup. And sometimes we do anticoagulation before surgery, prior to taking the patient for a radical nephrectomy, especially if there is complete occlusion or near complete occlusion of the IVC, or if there's evidence of a Blaine thrombus. We generally do not do embolization prior to surgery at this point, and we never put an IVC filter for these patients with IVC tumor thrombus, even if they have pulmonary embolism. We always discuss with the cardiac anesthesiology team. We talk to cardiology before surgery for the high-level thrombi, and we work with vascular or cardiovascular surgery for these high-level thrombi. We have a special operating rooms for these surgeries. There are big rooms where we can get a cardiac pump in there in case we need to go on cardiac bypass. And we have a dedicated team. So although we have 20 urologists in my department, there's only 3 of us that are allowed to do these surgeries. So it's very centralized, even within our department, to make sure we have the best outcomes possible. And the same thing is for the vascular surgery. Not all the vascular surgeons can do this in our center. And also we have cardiac anesthesia that are very well versed with pumps, with transesophageal echocardiogram, and we work very closely with our blood bank to make sure we have products available. Now, for the intraoperative exposure, in our place, we normally do these cases in a supine position. We give all these patients subcutaneous heparin. For the high-level thrombi, we do TEEs. We prep the patient, and we do it generally a midline incision is what I've done. And then we use what's called a Thompson retractor. That's what we have, and it works really well. And this is just an example of the incision that you see here. And actually, this exposure is from a post-chemotherapy RP-LND, not from a thrombus case, but just to show you what kind of exposure you can get without anybody putting their hands inside. This is just the retractor doing all the retraction, and you can see the entire exposed retroperitoneum here. So we found that using this retractor is very helpful. The only problem with this retractor is that it's very expensive, but we have available in the operating room at this point. So for the level 0 to 2 thrombi, what do we do? So no matter what side the tumor thrombus is, I always start on the right side to expose the IVC, the aorta, and the renal arteries. So we do what's called a Cattell-Brash maneuver. And what it is essentially a right-sided medial visceral rotation. And I'll show you what that means. So essentially what we do is the first thing you mobilize the right colon, the hepatic flexure of the colon. So that is moved away from the right kidney and gyrotous fascia. And then you do a complete Coker maneuver to mobilize the duodenum and the pancreas off away from the IVC and the aorta. And finally, you open the root of the mesentery. And then what that does is that the entire bowel can be removed off of the retroperitoneum. And this is kind of what it looks like. You see the bowel up here with the black arrow. It's off of the retroperitoneum. And what this does is it gives you this kind of exposure. So you could see the bowel is behind the metal retractors here. And the key point I want you to see here in this anatomy is that this is the aorta. Again, this is actually from a nerve-sparing RPLND that you could see the nerves here. But the most important point in this slide here is that the right renal artery is posterior to the left renal vein. And that's extremely important to note whether you're doing a right side or a left-sided surgery, because if you're doing a left nephrectomy, you want to preserve the right renal artery, of course, and that's why you have to clean it away from the IVC. So when you're doing the IVC thrombectomy, you don't accidentally injure the right renal artery. But the other important point here is that even though we're doing a left-sided nephrectomy and IVC thrombectomy, I always start with this exposure because always you can get the left renal artery controlled from this exposure. This is a right-sided exposure, but you can control the left renal artery. And in my mind, it's important to control the left renal artery in this fashion so that you don't manipulate the tumor on the left side. So here in this exposure, we haven't really done anything on the left side at all. And that's why I like to get the artery controlled here on the left and then do the IVC thrombectomy before even doing the nephrectomy. And I'll go into details of that in a moment. This is just an higher magnification view. You can see very clearly the left renal artery over here, and you can easily access this from a right-sided approach without maneuvering the left kidney at all. So when we have a right-sided thrombectomy, we find the right renal artery, and we always find it in the interaortocaval space. And that would be right here if you can see my arrow. So always find the renal artery in the interaortocaval space. And it's always posterior to the left renal vein. For right-sided cases, we control the right adrenal vein, the gonadal vein, and all the lumbar veins. And I call this the caterpillar. It's, the insect that you might be familiar with, and I'll tell you what that means. And I use this terminology with my fellows as well to explain what is the best way to control the lumbar veins. The IVC essentially needs to be floating. Nothing needs to be holding the IVC down to the spine. And then we isolate the left renal vein and, of course, the IVC above and below the thrombus. So this is what I mean by the caterpillar. So as you know, this is an insect that has a lot of legs. So this is the analogy I do for the IVC. So the lumbar veins in general are present at 5 and 7 o'clock of the IVC. As you could tell, they have very unreliable width, length, number, and location. On the other hand, the lumbar arteries are very reliable. They're always the same place, they're always symmetrical, they're always equidistant. The lumbar veins can do whatever they want, so we have to keep that in mind. I like to control these lumbar veins as they enter the IVC, so very close to the IVC before they bifurcate. And the most important point here is that you control them when they're on tension. Again, this caterpillar analogy. And same thing we do for the renal artery when you think of nephrectomies. You always have the kidney on tension, and then you find the vessels and control them. You don't want the vessel to be floppy or to be tortuous when you control it. So this is the caterpillar sitting. So in the blue here, that's the IVC. You see the lumbar veins are very floppy, and it's dangerous to control them this way because you can easily injure them with the instrument that you're trying to use. However, when you pull the IVC towards the ceiling, towards 12 o'clock, you can use any type of instrument to do that. Then the lumbar veins are straight and they're tight, and it's much easier and safer to control them. And that's how we do control the lumbar veins. And I generally control all the lumbar veins within the surgical field that we're going to be clamping. And these are some of the tools we use. We use the regular pot scissors. We use reverse pot scissors. We use the Cooley scissors, the Satinsky clamp. We have curved iliac clamps, otherwise called as Cooley clamps as well. There's a Glover clamp, and you can see there's different length, different angles that you can use. And we have an aortic clamp, which is a very large aortic clamp, and a Crayford clamp, which is a slightly smaller version of the aortic clamp. So what we do is for the right side, we clamp the IVC below the thrombus, then we clamp the left renal vein, and then we clamp the IVC above the tumor thrombus. Again, here what we've done is we've already controlled the lumbar veins, the adrenal vein, and the gonadal vein. I like to open the IVC wall with a 15 blade, and then we resect the IVC wall, including the renal vein ostium, with a combination of the different scissors that I showed you. We clean the IVC with heparinized saline, and we close it with 5-O-proline running sutures. In general, if we are going to narrow the IVC by more than 50%, we go ahead and do a patch, and you can use different types of materials that are available in your hospital to do that patch. We usually use biological material to do that. And then once the IVC is done, then I do the nephrectomy. That's the last thing I do. So here, just an example, you could see a bunch of clips and silk ties in black here in the intra-aortocaval space. Here you see the IVC just being isolated in the suprarenal space. And this is just an example of the IVC with a tumor completely removed and the IVC wall intact with clamps below and above. And just an example of a specimen. And this is how it's supposed to look like when you're done with very minimal narrowing, as you could see here. Now, for the left-sided thrombus, it's very similar approach. So we have the right side exposed. We control the left renal artery. All I do is put one silk tie on it. There's really not much space to do more, so I don't have enough space to divide it quite yet. But all I have is the artery is controlled. It's got a silk tie, and we can do the rest of that later. The other important part that I mentioned earlier is that you have to make sure that you lift the IVC off of the renal artery. because you want to preserve that renal artery. You do not want to injure it. And this is again because the tumor is on the left side. And the same thing, you control the gonadal veins. The adrenal vein here is very important to keep in mind that we want to try to preserve it because we are going to take the adrenal gland on the left side for a tumor thrombus on the left. We want to preserve the right adrenal vein. So what we do in general is you either put a very loose clip on it that you can remove later, or you can do what we call the PAUS maneuver. You can use a double vessel loop on the adrenal vein and then put a little bit of tension on it to occlude it. So when you do the IVC thrombectomy, it's dry inside the IVC lumen itself. And then you can release that PAUS loop, and then the adrenal gland will still work normally after that, the right adrenal gland. Again, you control the lumbar veins, same concept here. And you control, usually we use clamps for these things. Again, same process. You open the IVC, you resect the ostium, flush the IVC, and then close it. And then if you need to replace part of it, then you go ahead and do that. And then what I do is I put all the bowel back into the abdomen, and then I do the nephrectomy on the left side, just like a regular nephrectomy. This is just a very short video of an open case. This is a left-sided tumor thrombus. You can see here the left renal vein is very engorged. Here you could see the aorta. And here at the level of this finger, you're going to see the left renal artery. And you could see here we're on the left side. That's the left renal artery being tied right now. And in here, the blue vessel loop is on the adrenal vein on the right side. So we're going to put some tension on it. And then you could see umbilical tapes. This is the right renal vein, of course. This is the infrarenal IVC. And we just go ahead and these are curved iliac clamps, otherwise known as Cooley clamps. So we start essentially from below the IVC, then the renal vein, then above the IVC. And then we open the IVC close to the renal vein ostium, and then it has to be completely dry inside. That's the best way to do this, is to make sure it's completely dry. Here we're using the POTS scissors, and it's very important to keep exposure and lift the tumor thrombus away from the IVC so we don't take too much IVC wall. And you could see here in kind of this little bloody area, that's the right renal artery, right here. So we see it's very easy to injure it if you don't keep an eye on it. It's right here. And then all this here is the tumor thrombus that you could see. And then once this is done, you could see under the gauze here is the tumor thrombus. We're just hiding it right now under this piece of gauze. And we're just go ahead and closing the IVC with running Prolene sutures. And then we will flush it with heparinized saline and then vent it by opening the clamps. And then we'll go ahead and tie that. And that's what the IVC would look like. And this is the intact right renal artery right here. So for level 3 thrombus, we have to do a little bit more work. We have to do TEE. We have to control and divide the short hepatic veins. We want to mobilize the liver lobes. You have to do a Pringle maneuver, and you have to clamp the IVC above the liver, but below the diaphragm. Now, the thing is, once the tumor thrombus is out of the IVC, then you can transfer the clamp from above the liver to below the liver, and then you can release the Pringle maneuver so that you don't keep the Pringle maneuver on the portal triad for too long, and you close the IVC wall. And again, the last thing we do is the nephrectomy. Now, for a level 4 thrombus, this is now above the diaphragm. For these patients, we always have the cardiac pump ready because these will involve a median sternotomy in a lot of cases and a bypass surgery with the cardiothoracic team. Just showing you some examples here of the thrombus. You could see the IVC in a longitudinal way. You could see the tumor thrombus here. Let me show you here some video, I think, on this one. So this is from our colleagues from anesthesia doing the TEE. For some reason, it doesn't want to work, but this is just an example of the tumor thrombus that you could see. The other thing that I've learned from my colleagues in thoracic surgery is you can access the chest through the abdomen. It's a great maneuver to access the heart without doing a sternotomy. And this is helpful for level 4 thrombi that are above the diaphragm and a little bit in the heart, but not too deep in the right atrium. And this is what it looks like. This is the liver, as you can see down here. This small section is the suprahepatic IVC. You could see a silk tie here. This is on one of the left phrenic veins, the right and the left hemidiaphragm. And of course, this is the heart over here. And you can have a good access to the heart in this way. And this is again only for lower thrombi. So we can clamp the IVC above the diaphragm, or you can even clamp part of the right atrium and do the entire operation from inside the abdomen. And again, avoids the morbidity of a median sternotomy. Now, looking at IVC surgical margins in general, we have noted that if you do have a positive vein margin, you do have a higher recurrence rate. However, most of these vein margins, when they happen in patients who already have metastatic disease or will have metastatic disease soon. And I don't think that the margin itself is related to the risk of developing metastasis. It's just an indicator of an aggressive biology in a very advanced stage. Now, as far as a need for resection of the IVC, there are two papers that were published on this, just trying to predict preoperatively who might need IVC wall resection and replacement. And the main predictors are going to be the right side, because of course the renal vein is closer to the IVC at this right side. And also the diameter of the IVC at the renal vein is a predictor of invasion and need for replacement. The other factor that was described is if it's completely occluded at the level of the renal vein ostium, that's a predictor that you might need to replace the IVC in that location. You might have seen some data on neoadjuvant therapy. There was a lot of excitement on that, many, many years ago with case reports. However, we've looked at this ourselves, and this is from Axel Becks when he was in the Netherlands, that not all patients respond to systemic therapy. And these are several retrospective studies that showed minimal response with TKIs to the IVC thrombus. However, a recent study from the UK, from the Nexiva study by Grant Stewart, showed that using axitinib, which is a tyrosine kinase inhibitor, resulted in a reduction of about 37% in the Mayo level. So the Mayo level itself was reduced by using this drug for about 12 weeks. However, in 4 patients, there was an increase in the length of the tumor thrombus. So about 40% of these patients were able to have a less extensive surgery after this therapy. However, we don't consider it at this point to be a standard of care. Now, this one that I showed you is called Nexiva. This one here is called Neotax, and this is a study from China using axitinib as well, plus toripalimab for 4 doses. And they have shown here in this graph 62% had a change in surgical strategy. Only 1 patient had progression of disease, but the level of the thrombus per se was still the same. And they showed a potential benefit of using this combination of PD-1 inhibitor plus a tyrosine kinase inhibitor. So recent data show some potential benefit. However, it's still not standard of care. Now, how do we manage people with tumor thrombus and bland thrombus? And this is a nice paper from the Mayo Clinic showing you here what you can do. So the first group up here, this is the vast majority of our patients. You just remove the tumor thrombus and you're done. You close the IVC. Now, if you have bland thrombus in the common iliac veins, then you can put a filter below the renal veins after you do the IVC thrombectomy. Alternatively, if the bland thrombus is going really high, you can just simply staple the IVC below the renal vein, or you can staple and interrupt the IVC below the renal vein so that you don't have bland thrombus showering up into the lungs. Now, this is a very relatively rare syndrome, but we do see several patients like this every year. Generally, Budd-Chiari syndrome is because you have a occlusion of the hepatic veins, and these are the symptoms that the patients present with. And this is how the scans look like. You can see the right liver is completely congested. And for these patients, we rarely do upfront surgery. There have been some reports of putting these patients on bypass, removing the tumor, bring them back a week later. We haven't really done that in our center. What we do at this point is we do a biopsy. We have the radiology embolize the renal artery. we do systemic therapy, and then we reassess. And if the liver is better functioning, then we go ahead and proceed with surgery. So this is an example of a patient that was successfully treated that way. You could see on the left side, the liver is very congested. On the right side, you could see that the liver is now normal. You could still see the IVC tumor thrombus. We don't expect it to go away, but it shrank just enough for the hepatic congestion to be relieved so we can do a safer operation. Now, this is something that you might see a lot in your practice is that people come in with a thrombus and then they have PEs, pulmonary embolisms. And then we always wonder, is it from the tumor? Is it bland thrombus? So this is what we looked at in our data. The survival of patients, whether they have a PE or don't have a PE, is really the same. So having a PE is not a contraindication to do an IVC thrombectomy. The thing is, you have to give them blood thinners for a few weeks before taking them to surgery to make sure that the pulmonary embolism doesn't get worse while you're doing the operation. Now, just the last couple topics here. There's definitely a lot of work on robotic surgery. I personally have not started doing robotic surgery for IVC tumor thrombus, but there's a lot of data on it out there. And I think for some patients, it makes sense, especially for the lower level IVC tumor thrombus. So it's definitely valid in the well-selected patient population. So just to finish up here, in patients with our kidney cancer and venous thrombus, if they have no metastatic disease, always take them to surgery directly. Ideally, this should be done in a high volume center with high volume surgeons. It's definitely a lot of multidisciplinary work and teamwork. And more than half these patients can be cured with just surgery alone. So if they're not metastatic, take them to surgery. And just some tips, always plan ahead, always review the images, always talk to your colleagues from thoracic or vascular if you need their help ahead of surgery. Make sure the operation has excellent hemostasis so you can see exactly what you're doing. Dissection should be very sharp, very clean, very meticulous. You should always know what you're doing. You should always see what you're doing. So if there's a lot of bleeding, then we're doing something wrong. We need to take care of that before we proceed with the actual IVC thrombectomy. And at the end of the day, you have to be very calm during the surgeries. This is not something that is a trauma operation. This is something that has to be done under complete control. And with that, thank you very much for having me today, and I appreciate the invitation.
Thank you very much, Professor Karam. Wonderful talk. I think some of these practical points can only be described the way you have described with the vast experience that you have in IVC thrombectomy surgery. So we're really very grateful for your participation in the course. If there are any questions to Professor Karam, please raise your hand or write in the chat box. Professor Karam, is that okay with you that we will be recording this presentation and this recording will be available to our delegates for subsequent viewing?
Sure.
Thank you very much. So
Thank you very much.
I don't think there are any questions.
Okay.
Okay, great. Thank you very much.
Thank you. Thank you, Professor Arthur. And Professor Hanan, sorry, I'm going to miss your talk. I have to run, but and I'll look forward to seeing the videos for both you and Dr. Aslam as well. So
no problem. We'll touch base at some point. I actually have some trial ideas on IVC thrombus that I want to run by you sometime.
sounds good. Thank you very much, everyone. Have a great Saturday.
Thank you very much. Bye. Again, honored to have Professor Rakibul Hanan again, second time in 2 weeks. Thank you very much for being here. And today he's going to talk about SABR for primary kidney cancer. So, Professor Hanan, the screen is yours.
Thank you so much. And thank you so much again for inviting me to talk about this. Let me put into presentation mode. Okay, so are you able to see the slides?
Yeah, perfect.
Okay, perfect. And Dr. Karam's talk was just in perfect time because it actually helps me with some of the things I will cover. So my disclosures, nothing to disclose specifically. So in the last module, I mainly covered the primary renal radiation for small renal masses and some experiences with ablation and salvage settings. So for this module, we will talk more about locally advanced and metastatic kidney cancer. I'll try to focus a little bit more on locally advanced and cytoreductive settings, since I actually realized that somebody else is talking also about oligomet. So I'll probably try to cover less of that, but let's see how much time permits. So with IVC tumor thrombus, we had a few experience of case reports where patients presented with level 4 IVC thrombus that were really refractory to systemic therapy and even sometimes not just surgical candidates. And we radiated them with very high dose of stereotactic radiation. This one was 45 gray in 5, and then there's another patient that was 50 gray in 5. And these are just case reports. This was the first cases. Interestingly enough, one of the patients that did have a follow-up. So out of the 2 patients that we talked about in this study, one of them had a 1-year follow-up. And in the 1-year follow-up patient imaging, you see C panel here is showing before radiation. This is the thrombus. And 1 year later, you see that the thrombus diameter completely has shrunk. The patient's Budd-Chiari syndrome completely resolved. So clear radiographic as well as symptomatic benefit the patient experienced, and the patient actually did reasonably well. So this really got us thinking that there could be a potential application for this to work together with surgery and systemic therapy in treating IVC thrombus patients. We did 2 things with this experience. One, we designed a clinical trial, which I will talk about down the line. And the second thing is, because these cases are so rare, we went around the world and asked other institutions that may have had experience, and we collected a case report of 15 patients from about 7 to 8 institutions. What we learned from the radiation of IVC thrombus is that overall almost 60% of them shows radiographic response. Almost all patients derive palliative and symptomatic benefits, and the toxicity or the side effect of these radiations are minimal. So we are now expanding this case series, again, going around the different institutions, and we have about 45 to 50 cases that the manuscript is being written now. We saw that the radiographic response remained about the same. 60 to 70% of the time there is radiographic response. It just does take some time, maybe up to 6 to 7 months before you actually see a radiographic response. I'll go over some cases because I think cases, that's really what we have for these rare situations. So here is a case of a 38-year-old lady who presented with flank pain. And then she also was found to have a large left renal mass with IVC thrombus that was extending all the way up to the right atrium, so level 4 thrombus. The patient clearly had the Budd-Chiari physiology with liver congestion and obstruction of the hepatic veins. She had elevation of the LFTs, but otherwise metastatic workup was negative. So she wasn't a surgical candidate up front, so she was started with immunotherapy, the ipi-nivo combination, and at the same time, we started stereotactic radiation to the thrombus. And here are some images. So the baseline, this is what the patient presented with. You can see that the thrombus extending past the diaphragm into the right atrium. You can see the white showing up in the MRI is the ascites. You can see on the right side of the liver is hypoperfused compared to the rest of the liver, and the white arrow is pointing to the right hepatic vein that is engorged. So then we started the ipi-nivo and then gave high dose radiation, 40 gray in 5 treatments. 6 weeks after the radiation, we already measured the LFTs, which was starting to normalize. You can see that the ascites before the radiation, and here is the ascites already decreasing after the radiation. And then 7 months later, you see even radiographically, the thrombus diameter decreased in size. The right side of the liver now is being perfused, no ascites anymore, and the LFTs are completely normal. So then the patient became a candidate for surgery and underwent surgery and nephrectomy and thrombectomy without any complications, and she eventually did well. Eventually, a year later, she did come back with metastatic disease, but that's, of course, another story. So another patient, 57-year-old, who presented with PE workup and was found to have the left kidney mass, that is T3, with IVC thrombus, but metastasis to the lung, liver, and lymph nodes. He was started with ipi-nivo, had a partial response, and because of the partial response, now standard of care would be to do cytoreductive thrombectomy and nephrectomy. Right before the surgery, we did an MRI of the patient, and the radiologist in the MRI pointed out, of course, in addition to the primary and the thrombus, they also pointed out an irregularity. I don't know how well you can see it here. There is an irregularity on the IVC thrombus wall, suggesting thrombus wall invasion. And then Dr. Karam mentioned that wall invasion poses extra challenge for surgical resection. It becomes a more complicated vascular surgery. So the decision was made to do a nephrectomy only, not a thrombectomy, and leave the thrombus to be taken care of for local control with radiation. And that is what we did. Patient underwent a nephrectomy first. And that nephrectomy, as you can imagine, would be much simpler and perhaps even be able to be done by robotic assistance. And that was actually the trial that I'm thinking about proposing, where in large institutions, you can only do thrombectomy, but in community and other sites, you don't have the technology and the experience to do a thrombectomy. Perhaps these complicated cases, you do a radical nephrectomy that may be robotic, and patient would have recovered within a couple of days. And then the thrombus is treated with radiation and given local control. So we did radiation 36 gray in 3 fraction to the thrombus only. As you can see, the primary kidney is not there. And this patient now is 3 years follow-up and doing very well. The thrombus continues to shrink, and there is no additional sites of progression. So maybe a good combination with surgery to give the patient full local control. Another one case, let's go over. This is a patient, 60-year-old, who had a remote nephrectomy first in 2009. Then later on, they could not do thrombectomy at that time, but the thrombectomy was there. Patient was treated with sunitinib. Later on, they went back and did a thrombectomy, but in 2021, the patient came back with a local recurrence at the thrombectomy site. So perhaps there was wall invasion and it was just not a clearly negative margin. But nonetheless, now the patient has a recurrence in the IVC thrombus only, nowhere else. Was not a surgical candidate, perhaps because of multiple previous surgeries. So we did stereotactic radiation, 39 gray in 3 treatments, and the thrombus showed nice response. And this is 6-month follow-up. You can see that already the thrombus is shrinking. And now is about 3 years follow-up, and the patient is still thrombosis control. So another application. So the other thing we did with our experience is to design a trial. This is a trial of neoadjuvant stereotactic radiation followed by thrombectomy and nephrectomy. The rationale for this trial is, one, we wanted to reduce the thrombus, make surgery easier, and perhaps improve on local control. Particularly again in the setting where you may have local IVC wall invasion. But the second idea was we wanted to give radiation to the thrombus, which may be more volatile and can shed more number of pulmonary metastases. By giving radiation prior to the surgery, we may improve recurrence-free survival, which was the primary endpoint. So we first published the safety lead-in 6 patient, which tolerated both of the procedures really well. Without any unexpected side effect. And we always worry about doing surgery in a radiated field. And for these patients, the radiation was immediate and surgery was within 2 weeks of radiation. So fibrosis did not settle in and there was no problems with surgery and no additional complications of surgery. Interestingly, the first 6 patients, 2 patients had metastatic disease and had a spontaneous abscopal effect. You may have heard about abscopal effect, where radiation and even surgery, rarely you see abscopal effects, where radiation induces antigen presentation and induces an anti-tumor immune response. We'll talk briefly about that at the end. But this is one of the patients there that had a lung metastasis that was clearly growing and underwent surgery at this time and radiation. Nothing to the metastatic site, but spontaneously the lung metastasis regressed completely. We were able to biopsy this tumor at this time before it regressed. And the biopsy showed a robust infiltration of immune cells, the CD8, CD4, and macrophages, suggesting that a robust immune response has been happening. So I'm going to move on now to cytoreduction of primary RCC. There isn't really much data, but there is 2 trials that are ongoing. The only data we have on cytoreduction is a pilot study of 14 patients that received stereotactic radiation before nephrectomy. It showed that the procedure was tolerated well, radiation was tolerated well, no additional complications of surgery, and that there was immune correlates or immune response induced by the radiation. A small pilot study, but it allowed 2 phase 2 randomized studies to be designed and ongoing. So cytoshrink is being done by the Canadian group, and this actually completed enrollment. So we will find out both of these studies are doing stereotactic radiation in the setting of IO, in the cytoreductive setting, so metastatic setting with primary being treated with radiation, trying to not only do local control, but also to help the immunotherapy have a better outcome for these patients. And we will find out how this goes. Another case I wanted to introduce, but before discussing this case, I want to introduce a technological advancement that allows us to treat these patients now, that patients with locally advanced treatment. This is what we are calling adaptive radiation. So stereotactic radiation, but with adaptation, meaning that we're calling this pulsar, personalized ultrafractionated stereotactic radiation. What we do is easy to understand. It's really adaptation to tumor response. So the most common adaptation that we see in response to radiation is tumor shrinking in size. Now, if tumor shrinks in size, we have to shrink our radiation field. Otherwise, as the tumor shrinks, normal tissue is coming into the radiation field, right? The second thing is oftentimes we are not giving enough time for the shrinkage to be seen. So this ultrafractionation refers to stereotactic radiation spaced out in time. So we give one treatment, we wait a month. And because we gave one very big treatment, we already treated the majority of that tumor and allowed the tumor to shrink. And then we bring in the next radiation a month later, but this time we adapt. We look at the tumor shrinkage or change, and then we adapt the radiation field. So this is what we did with this patient with clearly a T4 tumor with liver invasion. You can see a really large right kidney tumor. And many times I get asked, okay, what is the size limit? There really isn't any size limit for radiation. It's more on what is nearby. But even in this patient with nearby bowel and duodenum, you can see it will be impossible really to locally control this tumor if we don't do anything other than the adaptive radiation. So that's exactly what we did. We gave a very high dose radiation to the entire tumor, and the blue here is the coldness. So that's the lower doses of radiation, and inside is very hot, much higher dose, because inside the tumor you have no worries of toxicity. There is no organs you're going to harm by giving high doses. But in the periphery is where you have the organs nearby with bowels, so that's where we're giving low doses of radiation. So we gave a high dose of 8 gray, and the inside of the tumor receiving 10 gray. We waited a month, and then we planned again. And what we saw is that with each treatment a month, the tumor kept shrinking, and we kept shrinking our radiation field with it. Eventually, we were able to deliver a tumor controlling dose. And this is the patient 1 year later. You can see significant shrinkage even out of the liver, fully locally controlled. The tumor continues to shrink as of now even. So the patient is doing really well. So this is what we are able to do now with the adaptive radiation, which is one of the newer forms of radiation or newer forms of stereotactic radiation. Okay, so with the remaining time, I'm going to switch gear to talk briefly about oligometastasis. So oligometastasis is, limited number of metastases from kidney cancer, typically 3 to 5 and really less than 5. And there is a wealth of surgical data, all retrospective, that shows that surgical metastasectomy gives overall survival to these patients. There is clearly selection bias in this setting in the retrospective data. But still, nonetheless, systematic review and meta-analysis have been done that showed metastasectomy improves survival in these settings. As a result, NCCN has accepted it and accepted stereotactic radiation as one of the non-invasive modalities of metastacectomy. We have published one of the largest series of reporting on 175 metastatic patients. So this is not oligomet. These are any number of met, because first we have to see if stereotactic radiation works for metastatic kidney cancer. So to prove that, we looked at this and we did see that there was very good 90% or higher local control when we treat metastatic sites with stereotactic radiation. Number of other groups have reported, and systematic reviews have shown that overall the local control rates can be well over 90%, typically 95 to 98% when we are targeting metastatic site with stereotactic radiation. So now we looked at applying this sequentially in oligometastatic patients with a curative intent, so the intent of controlling their disease overall. So these are patients that are presenting with 1, 2, or 3 sites of metastasis. We give them stereotactic radiation, and then we keep watching them without anything else. And if they come up with another site of metastasis, we then go after that with stereotactic radiation. We keep doing that until we are not able to do it anymore, or too many sites have shown up, and that's when they start systemic therapy. And by doing this strategy, which we're calling sequential radiations or sequential stereotactic radiation, we saw that overall, we were able to control these patients for a median of 15 months, which at the time when we published this study, that was significant. The original TKIs, really the median PFS were on the order of 12 to 13 months. It's only now with combination that we are seeing medians that is better than this. Nonetheless, this was very encouraging. We recently published, this was published last month, our update of that study where we expanded that 47 patient cohort to 153 patient cohort. The main purpose was to identify patients that are doing better. So this was more on prediction, and we did AI or machine learning based modeling, and we reported on 3 parameters that predicts patients who has done better. So one is lower number of metastases. Then the patients with bone metastasis and brain metastasis clearly does worse. So those patients perhaps should not be selected for this sequential SABR paradigm, but rather go on to systemic therapy. But nonetheless, all of these patients with 27 months of median follow-up had a median PFS of 32 months. Again, that's really impressive. So we went ahead and did a small phase 2 study, a prospective phase 2 study, where we confirmed that indeed we can reach median PFSs that are more than 2 years. And we measured patient-reported quality of life and showed that quality of life did not decline in these patients. We are updating this study now that hopefully will come out soon. 2 other institutions reported. One of them is from UK with a multi-institutional study, and MD Anderson also reported, and both reports were fairly similar in experience to ours. We then went ahead and designed a phase 3 randomized clinical trial that is now enrolling, where we randomize these patients with sequential SABR followed by systemic therapy at progression versus upfront systemic therapy. And the goal is non-inferiority with a co-primary endpoint of toxicity. The idea is that if we are able to really extend this time of delaying systemic therapy for these patients, that's really good quality of time that the patients are experiencing as long as the survival is not compromised. There is quite a bit of data for stereotactic radiation for intracranial metastasis, where local control is 100%, and same thing with spine, where the local control is on the order of 90%. Spine cases get to be really complicated, and we always manage them together with the surgeons. A little bit on oligoprogression. So oligoprogression is when the patient with metastatic kidney cancer is on systemic therapy. They are responding to systemic therapy except for 1, 2, or 3 sites that have become resistant. And a large number of sequencing, gene mutation sequencing studies suggest that as clonal metastasis happens, each clone can have preferential different set of mutations that can build up, that can make them selectively resistant to the systemic therapy. In that setting, if we take out those sites with stereotactic radiation, the patient now can continue on the systemic therapy, which otherwise is working and otherwise they're tolerating well. And as it is, we know that systemic therapy options are not too many for kidney cancer patients. So we looked at retrospectively of 51 patients, and we saw that on an average, we can increase the median PFS of the systemic therapy by 8.6 months. And for these patients, when the systemic therapy is immuno-oncology agent, IO agent, or immunotherapy, we know that their PFS can be significantly better. So again, suggesting stereotactic radiation may have some interaction with the immunotherapy to induce antigen presentation. Canadians reported on a study primarily on TKIs, in fact, primarily on pazopanib and a few patients, primarily on sunitinib and a few patients with pazopanib, and they showed similar findings of increased PFS by about a year. We completed also a phase 2 study where we reported the increase of PFS to be approximately a year, so 11.1 months. Again, we noticed the trend of better combination in the setting of IO. Two small phase 2 studies are ongoing now that we will find out results, one from France and the other one from Yale. Lastly, we are now designing a phase 3 randomized study that we are proposing to NCI for funding with a similar concept where we will incorporate stereotactic radiation for patients that are oligoprogression on systemic therapy. So the last topic, briefly, very investigational. Can SABR increase immunotherapy response? So can radiation do the immune modulation? And we know there is a wealth of preclinical data on this, where radiation kills the tumor cells. It induces an immunogenic cell death. It draws in the dendritic cells that can take up the tumor antigen and then migrate out and present the antigens to the T cells, cytotoxic T cells and T regulatory cells, to prime them, which now then can go out and treat the tumors, not just where it was radiated, but also to the metastatic sites. This entire hypothesis has been proven multiple times in preclinical studies, but no good clinical trials yet. So we're calling this strategy the iSABR strategy. We and a number of other groups have looked into clinical trials. I'll go over some of them briefly. So the IL-2 trial, where we combine high-dose IL-2 with stereotactic radiation. There is the RADVAX trial. Let's go over these trials very briefly. So the IL-2 trial, we enrolled about 20-some patients, but in clinical response, we could not improve the clinical response of historically reported IL-2 alone. We did do an extensive number of translational studies and learned a lot. We learned that certain patients do better in this setting when you're combining with stereotactic radiation. We also learned that patients with a higher tumor neoantigen load does better with this strategy, but overall, this did not change practice. The second trial we completed together with Dr. Hans Hammers in our institution, combining EP-Nivo with stereotactic radiation, enrolled about 25 patients. It was safely and was tolerated well. Overall, it did not, well, it did increase response rate to 68%, whereas the historic control is 40% response rate. It did not include complete response rates, though. So some indication of success here with partial response increase. The other trial I did not go over is the NIVES trial. It is a single arm, actually it's a randomized study of combining nivolumab single monotherapy with stereotactic radiation. Also did not show that it increased the response rate. So far, no solid trials to hang our hat to show or conclude that stereotactic radiation increases the outcome of immunotherapy. Our latest endeavor is here, where we are combining this pulsar radiation, which now, remember, spaced out in time for every 2 or 3 or 4 weeks, allows the cancer vaccination schedule to happen, because previously we were giving radiation, we were bringing the dendritic cells in, and then the next radiation is killing all those dendritic cells. So now that we are spacing it out, we really hope that this will improve the immunogenic response from radiation. We are combining that in patients that are oligoprogression, metastatic kidney cancer patients with oligoprogression after EP-Nivo on maintenance Nivo. We will add stereotactic radiation and combine that with intertumoral STING agonist, which significantly has shown to increase the antigenic response or dendritic cell activation by radiation. So in conclusion, we know that stereotactic radiation works. For locally advanced kidney cancer, we are able to do fairly well local control. Even for IVC thrombus, as much as 60 to 70% of the time, we will get a radiographic response. Almost 100% of the time, there will be palliative and symptomatic benefit. So how can we use that? We can use that together with surgery for patients that are surgically unresectable or refractory. Also, we can alleviate the Budd-Chiari syndrome and the venous congestion, making patients now eligible for surgery. Other settings we can explore, and we're thinking about combining neoadjuvantly or adjuvantly to confer durable local control for IVC thrombus complicated cases that are difficult for surgeons. In the oligometastatic setting, SABR is considered a standard of care for selected patients. Phase 3 trial is enrolling. In the oligoprogressive setting, number of phase 2 studies have been completed, and SABR can be considered in selected cases, but again, no prospective large trial is available. We do think that in the setting of IO, this strategy works better. Other places we are exploring is cytoreductive nephrectomy in the setting of immunotherapy and immune modulation. That's all I have. Thank you for your attention, and happy to take questions.
Thank you very much, Professor Anand. Indeed, again, a wonderful talk, and I think we have very comprehensively covered the subject of the emerging role. I think it's more than emerging now of radiation for locally advanced and even metastatic kidney cancers now. There are a couple of questions here, and one of the audience wants to know if there are any clinical or molecular markers at the moment which can predict response to radiation in these patients.
So the only ones we have explored so far is in the oligometastatic setting, where we had that 154 patients. So we have a larger experience, and we could do some modeling, and simple modeling like Cox regression, but also more advanced machine learning based modeling that revealed that patients with bone metastasis and brain metastasis do worse with stereotactic radiation. So those patients need to start systemic therapy earlier. Local control is still very good, just that these patients will fail elsewhere. Same with patients with larger number of metastases. Now, separate studies we have done on local control, on which patients do worse in terms of local control for radiation. And interestingly enough, we learned that patients that had multiple previous systemic therapies actually have more radio-resistant metastases. So those patients need higher radiation dose to improve local control. So those are the two we have done so far. The third one is oligoprogression. So that work actually is being done right now. And hopefully we will publish in the upcoming months. Now we have large enough patients built up of oligoprogression treated with stereotactic radiation, and we are looking into factors of what factors allow patients to have better outcome and local control as well as systemic control. So yes, very interesting question, and a lot of research going on that topic.
Thank you very much. One other thing that some of our radiation oncologists are concerned about is the bowel toxicity, particularly for the tumor in the location that you have talked about. So any tips and tricks in selecting patients? And
yeah, absolutely. As treating primarily kidney cancer, I have to come across bowel and bowel toxicities all the time. So yes, there is a number of tricks that we do. So the first one is, so one thing is technology. There is nothing better than technology, right? So you would have to have IGRT. You would have to have proper setup. The second thing, stereotactic radiation, in addition to that, the adaptive that I mentioned really helps. So even before adaptive, the standard techniques of motion assessment and motion management is something that's really vital. And I can give a separate talk on that. But briefly, you want to do some sort of gating for motion management. You want to do either abdominal compression or breath hold techniques for motion assessment and reducing motion. So motion becomes very important. The second thing is bowel moves day to day. So that's why adaptive radiation becomes so much important, because where you plan, by the time you're delivering the radiation, the bowel has moved. So if you are able to do online adaptation, that is ideal. even if you don't have the adaptive technology, just spacing out the radiation really helps with GI toxicity directly. So if you, instead of the same dose you're giving every other day, if you space it out one treatment every month, you will have significantly less bowel toxicity because bowel regenerates in the meantime, but the tumor doesn't because you have given a high enough dose. Lastly, other simple things, I always put the patients on protonics for about 6 months, starting before the radiation. That reduces acid and reduces duodenal ulcer probability. Second thing is I always give sucralfate for each of the patients. This is the Carafate. I give 1 gram before radiation, about an hour before. This is again mainly small bowel. It doesn't really help you with large bowel, but small bowel and duodenal toxicity, it will reduce. So those are some of the tricks that you can apply even if you don't have that advanced technology of being able to do adaptive radiation.
I think one last question, I'm sorry to keep you engaged, is about the use of radiation for level 3 and level 4 thrombus. We know that Jose Karam is not there in every institution, so the surgeons are really very apprehensive operating on those patients. So, what are your final opinion about 3
Yeah.
and 4 thrombi?
Absolutely. I mean, that's the one that really is motivating me to design this trial, which, as with every trial, the funding is always the problem. Now, this is, I think, a really interesting trial where what we'll do is a patient coming in with level 3 and 4 thrombus, the surgeons are still comfortable doing a radical nephrectomy and don't even touch the thrombus. For those patients, either before surgery or after surgery, we give a full definitive dose of radiation to the thrombus only. We are also not treating the primary tumor unless the surgeon wants us to treat it. So that way, your surgeons, even not being Dr. Karam, should be comfortable doing even robotically, just removing the primary big kidney tumor. Which also is difficult for us to control with radiation and bowel toxicity and all of that. So that part is taken care of. And now what remains is the thrombus where we give the high dose radiation. And both together, now you give patient a full local control, at least on the primary. And then if, of course, they develop metastatic disease, that's a completely different story. That's a trial that I want to do. I'm proposing a phase 2 randomized study where one arm just gets the thrombectomy. And then the other arm gets this strategy. And we follow the patients for both toxicity, hospital time, recovery, surgical morbidities, and mortalities, and compare. And if it's non-inferior, then this is now an option for community sites and other sites where you don't have access to extensive surgical equipment or surgical skills.
Thank you very much, Dr. Hanan, and that was wonderful to have you and hope to engage you on some other forum at different time.
Absolutely. Absolutely. My pleasure. Really an honor to be here and to be talking to all of you. Please feel free to reach out to me and look forward to future collaborations.
Thank you very much.
Okay. Bye.
Thank you.
In the end, Mr. Zishan Aslam, he is going to tell you which tool you use for removing the large kidney cancers. Is it robotic, laparoscopic, or open? He has good experience of doing it open and laparoscopic, and I'm sure that he will soon be a robotic surgeon as well. So, Zishan, the floor is yours.
Thank you very much, Prof, for keeping us all involved, and it's such wonderful to see how our certification course is evolving. So I'm Zishan Aslam. We have obviously met before, all of you, and consultant urological surgeon. First of all, amazing two talks, and after two such elegantly high-powered talk, I'll just take you through a little bit more lighter stuff, hopefully. So the talk is on radical nephrectomy and the three different modalities. So what are the different advantages, indications for that in the current times? So we will be touching on open radical nephrectomy. What are the current indication? Laparoscopic radical nephrectomy, this is the main bulk of the talk. How it has evolved over the years and how it is benefiting. and briefly on the robotic approach. The talk is not about the technique of doing the procedure and all, which we can hopefully touch on with your with the practical part of the curriculum. It will be more about evidence and see how things have moved on. So a disclosure, if I may call it disclosure, in the sense that I'm a big advocate of that, of introducing laparoscopy in settings of our parts of the world, and this is my own organization, which has been active in Africa, several centers, and also in some institutes in Pakistan with the help and support of colleagues like Professor Hamad Athar. So this is something which I would always be prepared to jump onto and advocate. So a bit of history, that the radical nephrectomy first described in 1952 by Frederick Foley, of course, open during that era, which was described as an en bloc removal of kidney with perinephric fat and gyrus fascia. So as technique evolved, as urology evolved as a separate surgical entity from general surgery, and we started to learn more about the urological oncology, this incorporated along with the nephrectomy, regional lymphadenectomy plus minus as needed. There are several approaches of doing open through anterior approach, various incision depending on the location and size of the tumor, and same with the flank. And again, wouldn't go into detail, and hopefully we'll touch on these topics and in the future. So open radical nephrectomy, it has remained a cornerstone of treatment for decades. But recently, as we have more smaller tumors being diagnosed, there have been role of active surveillance, ablations, laparoscopic radical nephrectomy, and of course, partial nephrectomy, whether open or MIS. So as you would expect, there's been downward trend in the open surgery. And that's we would expect, and that's how it should be of colleagues taking up laparoscopy. So timeline, if we just briefly touch on that this was one of the earlier series published, from a SEER database of over 6,000 cases of only T1A tumors, that is up to 4 centimeter between 1998 to 2005, and that has suggested that open radical nephrectomy decreased from 89 to 66%. The laparoscopy had started at that time, but the utilization was still low. However, the open partial nephrectomy had increased from 7 to 29%. So in 90s, contrary to what we think that open radical nephrectomy was getting converted into laparoscopy, that was not really the case. It was basically getting more conversions into partial nephrectomy. Partial nephrectomy was evolving at that stage. So this was another timeline study from American Board of Urology case log data in the second decade of laparoscopy, that is 2002 and 10, where it suggested that open radical nephrectomy has reduced, but lap radical nephrectomy has increased from 30 to 39%, as well as lap partial nephrectomy, as laparoscopic surgeons who had taken up laparoscopy were getting more and more experienced. So laparoscopic approach introduced by 1990s by Professor Ralph Clayman, and there's been widespread uptake in the subsequent years to follow over the last 45 years with excellent oncological outcomes. However, open radical nephrectomy still has comparable oncological outcomes. So where does the benefits of laparoscopy lie? So for that, we will go through some literature. So this initial series of 9-year by none other than Professor Clayman's team, the very earliest experience, you would say, looked at 61 cases of laparoscopic versus 33 contemporary open cases of tumors T1, T2 up to 10 centimeters. And it is clear message was sent that it has advantages with significantly reduced blood loss, hospital stay, and time to recovery. And especially important is the time to recovery, like 3.6 versus 8 weeks, and that could be really important in the healthcare setups and social setups where patients need to have early return to work, where they don't have like 6 weeks of paid leave after an operation. So that's where it is really important. There was longer operating time in lab group, and that is understandable, very early duration. And at 2 years follow-up, the oncological outcomes were not comparable. So we got the first advantage, laparoscopy. So as experience evolved, this series, it was from All India Institute of Medical Sciences, was published, and they were purely clinically T2 disease, mean tumor size 10 centimeters in both group. And that has again, even with slightly bigger tumors, gave the same message: significantly blood loss, analgesic requirements, hospital stay and time to convalescence, right? So we had further verification of earlier findings, as you would expect. There was a slightly longer operating time, which, I mean, you can see the p-value, but I think 15 minutes in real life doesn't really matter much. Oncological follow-up at 5 years, there was no difference noted. So we would now move on to larger tumors, greater than 10 centimeter, 360 cases. Some of them were greater than 10 centimeter, with the largest as 21 centimeter, with a mean operating time for 170 minutes. Again, same findings about estimated blood loss was 150 mils, hospital stay was 2 days, 2 minor complication, and their message was larger tumors can be done with appropriate patient selection. Like, you have to look at other factors, patient's BMI, medical comorbidities, no previous surgeries, surgeon's experience. Like, obviously, you need, just like any other surgery, you need to do easier cases first, and once you have got enough, then larger tumors can be treated. So this was a step further for T3 renal cancer. This study was by some of my colleagues I have met in after moving to Scotland, and some other from the UK, with pathological T3 stage disease, not IVC thrombus involvement. They also included some cytoreductive cases as well, with a conversion rate was noted to be 6%, which is, I would say, slightly more than what we normally have. Not like a hugely high conversion rate. Minimal claim in 3A complications and 4A complications. So this study proved feasibility for both metastatic as well as non-metastatic locally advanced disease, not involving IVCs. So, I mean, there's a lot of evidence from 2000s, and I can keep going all day, but the message is clear that laparoscopy has clear advantages in post-operative recovery, which are not just with smaller tumors, which were in the early phase. We don't even do full radicals for them now, but for more advanced disease, for bigger tumors as well, the advantages are clear, and this is something which should be adopted if your hospital environment resources allow you to pursue that. And I'm especially talking about in context of our SAARC region, South Asian region, where we still are lagging behind in laparoscopy. So I'll briefly just mention about this hand-assisted as well, that in an early phase, hand-assisted technique can be used as well. We never had that in urology in UK. In Pakistan, I've come across that with in PKLI doing donor nephrectomies. In States, I have occasionally come across colleagues, some residents I have met during workshops in Africa, or briefly, I think when I was at MD Anderson with Professor Karam for a few weeks, I think someone mentioned that some centers somewhere colleagues do laparoscopic hand-assisted as well, not at the MD Anderson itself. So comparable recovery, morbidity, cost, shorter operating time compared to pure laparoscopy, because you have direct control of the operating field of the hilum. So it's a natural tendency that our speed slightly goes down. You become more cautious close to the hilum. So that's why it is a little bit more quicker, and it is useful in early learning phase. So I'll show you a bit of a video of hand-assisted one, which we were using in Nigeria to teach them, just so that you can take a bit of a break from all the so much evidence I've been talking about. Calm down. And can just show it in there. Wow. So this was in Nigeria, and you can see the amount of stress and pressure that you have operating in that environment with the noise and all. So this is not a bad option in the early phase if someone is adopting laparoscopy in an environment in a hospital where you have minimal experience in the colleagues around you. And once you get a bit more experience, then clearly one can always use pure conventional laparoscopy. So we have demonstrated the advantages. Open radical nephrectomy now, has it still got a place? Of course it has. It is a very, very important place at the even in this time and age for very large masses. And how large is large? Personally, the maximum I have done is about 12, 13 centimeter, but I have a colleague um, um, 50 miles away who has done 15 centimeter, and I know colleagues who do 18, 19, 20 centimeter as well. So these are all fine as long as we are not doing a laparoscopic an open radical nephrectomy for a 5 centimeter tumor, which should be either lap radical or partial open or lap, whichever one can do. IVC thrombus, and I think we already had discussion on that. That it is, to me, the standard of care is still open radical nephrectomy with thrombectomy, especially for higher levels with circulatory support is needed, hepatic mobilization is necessary. And some cases of cytoreductive nephrectomy, multiple previous abdominal surgery where you can either go retroperitoneal laparoscopy or you can just do transperitoneal surgery as an open technique rather than laparoscopy. So cytoreductive nephrectomy, open or lap, I've done about 40, roughly 40, 45 cytoreductives, and a big proportion of them are lap. But, and you can imagine that the advantages of laparoscopy will be there as well, especially in the context that these patients may go on to have SECT, systemic anti-cancer treatment. So the quicker they recover, the better it is. However, you could come across large masses with Hylar node, increased vasculature, which makes surgery difficult. And that's where I have done some of them as open as well, and I have converted some of them as well. There is no shame in doing that for the patient safety point of view. From a personal experience, and I think Prof will agree with me on that, that there's more tissue reaction, there's a plastic reaction, especially with post-SECT cytoreductive, what we call as consolidative surgery, where it could be really challenging with dissection. So you just have to balance it that you are aiming for a less morbid operation for good reasons, but you don't end up making it as a more morbid one. You can always start the procedure laparoscopically, and if there are any issues, just nobody, I don't think anyone can punish for doing an open conversion, and I have done for some of my cases. So this was a series by Professor Debril Gill on a small series of lap versus open, mean tumor size 8 and about 10 centimeter, comparable outcomes. And they mentioned the same point that the patients had lots of perihilar lymphadenopathy. There were numerous parasitic vessels, which can make procedure difficult. And a very good suggestion point they have, key point they mentioned is adequate laparoscopy experience necessary. So basically what they mean is that you, I mean, it doesn't mean you need to have done 100 of laparoscopic nephrectomy, whatever number, 20, 30, when you feel comfortable, when you have developed good mature skills, then you can start doing this procedure. And I'll just show you a couple of my cases. This gentleman, 60 years of age, 11 centimeter mass in 2017. I had 2 lung nodules, which were for observation after cytoreductive. And unfortunately, one of my two cases who had developed a minor duodenal injury, and that was all because of all this adhesions, very sticky kidney, as I call it. And but fortunately, not significant damage. General surgical colleague had came and put a couple of stitches, and we completed it laparoscopically. So this is exactly what one need to have developed. Another case of a 3-year young man who presented with the cord compression. If you see the middle MRI scan with this arrow, and had emergency radiotherapy, and he was also had other management. And you can see this ugly looking mass on the left. He was and his lung was full of metastasis. You can appreciate a few on this image on the left as well. But he had a fantastic response to SET, and it was 3 years later. The picture on the right, you can see mass is so small, 5 to 6 centimeter. And at that time, I'd done a laparoscopic cytoreductive or consolidative cytoreductive nephrectomy. It went well, no complication, but I just put it because it was one of the most challenging in terms of dissection I had done. So these cases, you have to do it once you have got an adequate experience in laparoscopy. So IVC thrombectomies, if we again continue with the role of open, like as I said, that for me, standard of care would be open procedure. If I, as a renal surgeon who know ins and out of all these things, have, God forbid, this issue, I'll go to Professor Karam and get it done, an expert in this, and get it done open. But there is evidence, like Professor Karam has said as well, especially with low-level thrombi, level 1 and 2, and some level 3s, not much with level 4. And as you would expect, there is advantage with lower blood transfusion, overall complication rate, but the major complication and 30-day mortality was similar in both groups. We don't have long-term oncological outcomes, which needs assessment. And there has been a lot of talk by both Professor Hanan and Professor Karam about IVC wall invasions and all. And that's where these discussions, which are for another time, that which technique would be better for dealing with some of the unexpected findings in such a complex disease. So those were the open scenarios, which I hope I have conveyed some points to you. And finally, this is not something I would really emphasize on, especially in the context that we are operating in. We are in a time my involvement has been in Pakistan and other South Asian regions, which I am aware of. Hopefully, we'll get involved there. That we still need to catch up with laparoscopy, and especially with the finances. We have so many healthcare issues, public health issues, child and maternal health, vaccinations, where I would always be discouraging bringing in robots. So, but however, we have to touch on this topic, that this was a big meta-analysis of robotic with laparoscopic and open radical nephrectomy, 64,000 patients. And compared to pure conventional laparoscopy, there were no significant advantages. In fact, there was slightly longer operating time and higher costs. But compared to open, there was the same advantages of shorter hospital stay, lower blood loss, and fewer overall complications. But we have these advantages purely with laparoscopy as well. So robotic radical nephrectomy during early learning phase, that could be useful before getting on to partials, which is nephrectomy, which is a more complex procedure. One can do a few robotic radical nephrectomy if the technology is available. And for morbidly obese patients, I mean, my evolving experience in robotics has been in pelvic oncology. I am a renal surgeon, like Prof said earlier, lap and open. But I see my colleagues do find it much easier to operate on morbidly obese patient. And there's evidence for that for partial nephrectomy. So I'm sure it is in radical as well. And it makes perfect sense if the outcome is better with that. So in conclusion, where does the benefits of laparoscopy lie? Comparable oncological outcome, but it is actually the perioperative outcomes, the post-operative recovery, where they go back to work quickly. Some earlier studies, if you remember, 3 versus 8 weeks comparison. And on that, I had written this kind of a commentary, an opinion-based commentary a few years back regarding the social benefits, because a lot of our patients are coming from rural areas. They may be sole bread earners for their family. They need to get back to their farms, kitchens, work quickly. Some of them are coming to cities for treatment from 150 miles away, and their relatives come along and dwell on the hospital footpaths, and they all going early discharges mean you are actually treating an entire community. So that is where we have to be pragmatic in how we approach minimally invasive surgery in some of our parts of the world. Open surgery still has a major role, and we have touched upon that. And robotic radical nephrectomy, again, it could be a good starting point for the learning curve before you move on to more complex renal surgery. Thank you very much, Prof, and everyone.
Thank you very much, Ishan. As always, a very rational, balanced talk. And I think it's particularly important for most of our delegates who belong to the developing countries, where Zishan, although work in UK, he has great experience of working both in Africa and in Pakistan. So he understands the complexities of functioning in our part of the world. And another important thing that I have noticed in all the three talks is that they were huge topics, and they definitely have huge knowledge and experience on those areas that they have dealt with. The time was the essence. I mean, all these three talks completed essentially in the allocated time. This is something that is lacking. Zishan, I'd like you to comment as well, that when we get the podium, we just forget about all the rest who are going to follow us. And this is something that is extremely important. So not only we learn the art of making a great presentation, and we have seen three wonderful presentations, to see how you make those presentations, how you build up a story, you talk about science, and you give a little flavor of your own experience, but also that you do all these things in the stipulated time. So thank you very much, Ishan. Any comments?
Regarding presentations and all, I think,
Yeah.
yeah, I think it's probably just a matter of time. One needs to get into the habit of presentation. Obviously, there was a time my presentation skills were average as well. Listening to the talks, and it's not just getting the scientific content, but again, what you had so kind of sharply observed in the talks, that is something to take home as well, and practicing as well. Often I come across, like, although this is like a bread and butter for me, and it's like me being at home, this whole session, मतलब मेरे घर की बात है, but still I have, after preparing, I've gone through it about 4 times, and each time I was polishing something. I'd even recorded it. I don't think I was going to share all the information. I'd even recorded it, the talk, yesterday, and then when I listened to it, I just managed to find how much unnecessary words which I was using, which I deducted in, and then this all these things allow with the time. But I think it's not just our own practice, but while this is what I would say to juniors and colleagues, that when you're listening to speakers, it's just about grasping what areas they are focusing on, what is the scientific content you as a listener like to listen to, and what exactly is not. And then it's all just practicing, which takes everyone there. Yeah.
Yeah, I think that's another wonderful point, which I have the experience of sending a couple of pre-recorded presentations to the meetings. There's so many invitations these days, and you can't really travel. So if you open up your Microsoft PowerPoint, you can go on to record, and you can record your presentation and listen to that presentation and see where you have made the error. And when you actually make those presentations in front of the audience, you probably would avoid those. So I do it all the time, and Zishan said. And I have heard from some of the biggest speakers in the world. I mean, people who can just close their eyes and be at a spinal level, you can truncate their medulla oblongata and they can still make that wonderful presentation. But these guys also practice it so many times before coming to the podium. So it's all about practice and making an effort and putting all the best that you see coming up in these presentations. So again, thank you very much, Professor
Just
Karam.
a question by Khalid Farouk, and I think you have partly answered. And yeah, Khalid Saab is absolutely right regarding laparoscopy in South Asia. I think, I mean, I have to say very frankly that when I talk about these things, I really don't count India in, because I think they are much ahead in urology, in many ways, than the rest of South Asia. I mean, and he's absolutely right. You are that they are ahead of UK in when the laparoscopy was taking off, and even robotics, I have to say. Yeah. So it's the rest of us, yeah.
Yeah, great. Thank you very much. See you in 2 weeks' time, and we have some very exciting presentations on cytoreductive nephrectomy for the ERAS protocol for renal cancer. And we have talks about systemic treatment with Professor Hussain again, and then SBRT for oligometastatic cancer by Bilal Qureshi. So hope to see you all next fortnight. Until then, thank you very much and have a very good evening.
Thank you very much. See you all.